straightforward, easy anatomical study on relevant to endoscopic approaches and with some clinical implications. It's teamwork, as always, from University of Cambridge, where I was with ENT, radiologists, and my colleagues in neurosurgery. It is about finding anatomical landmarks that help people during complicated pathological distorted anatomy through the extended endoscopic approach, mainly for transclival approaches. It is straightforward for the experienced surgeons. This is not meant to be for them. It is common knowledge. And it's all started many years ago when we were setting our endoscopic service, and we had input from Dr. Amin Qassam, where he visited us in Cambridge. And again, I used some of the anatomical images from Professor Roten about finding landmarks. And the floor of the sphenoid sinus is a good landmark when you are doing this procedure. It's the same as the manubrial angle for anatomists, finding where for example, where is the trachea bifurcates and the thoracic ducts and so forth. So this is just for orientation. And mainly the transcrival approaches are mainly through the clivus. And when you have an intradural extension, it goes to the prepontine space where you have all these vessels with the basilar artery and its branches. So the whole rationale of the study is to define anatomical corridors, looking at studying the preoperative images and knowing where you will find these retroclival lesions in relationship to the cavernous sinus, to choose your approach, whether you go through the sphenoid sinus itself or below it or extend it. But it's mainly, I will touch how we try to find the sixth nerve for those lesions that are intradural and distorting the anatomy to save the sixth nerve during the procedure. We also studied the carotid artery, but we did not add in our studies to what is already been in the literature. So as you can see, this is the transclival approach endoscopic. You can go through the sphenoid sinus or below, or even down to the craniocervical junction. Inside, this is what you see, but this is the approach. You can see the relationships is mainly the basilar and the sixth nerve, and of course the carotid on either side. These are the neurovascular relationship that is important to the sphenoid. You all know that the clivus has an upper third, the dorsum telu, with the ficus apex here, the middle third with the jugular foramen, and the lower third. But it's the relationship of the clivus is the most intimate, is the sixth nerve, as you can see here, going subperiosteal and then going eventually in the Dorellos canal. So the clivus is a long bone that has segments, and this is part of it is exposed by the sphenoid sinus, and these are the structure behind it, and you can see the relationship of the sixth nerves becoming more intimate as you go upwards. And this is the relationship of the cavernous of the sphenoid sinus to this junction and the origin of the sixth nerve. So this is a complete exposure anatomical of the clivus, but only the upper part that is reached by the sphenoid sinus. And you could see the sphenoid sinus lower part exposes mainly the vertebrobasilar junction. But below any lesion that you see in the scan related below that, you would need to go below the sphenoid sinus, as most of you know. And this is here, the relationship goes on the AP and the lateral, and note that the basilar is in many cases not in the midline, the vertebrobasilar junction in one side or the other. So we studied what is the relationship between three areas anatomically that are all on the same area. So usually the pontomedullary junction is where the sixth nerve emanates, and it's where the origin of the vertebrobasilar junction. So this point here has all these three important structures, and whether it is related to the landmark, which is the floor of the sphenoid sinus. And we did a radiological study and a cadaveric study. It was all done in the University of Cambridge. We used the cadavers, and we did surgery on it on 5 cadaveric heads, and we scanned the specimen before we started. and it was straightforward. There were different types of sphenoid sinus aeration, and the vertebro-basilar junction, when we opened the dura and its relationship to the sphenoid floor, and you could see it is a good landmark. Not exactly, but it is very good landmark. But as that was a limited study, and we subjected 100 people who have normal MRIs for different reasons, and we did the radiological study to see whether this will apply or not. We localized the vertebro-basilar junction both on the T2 weighted axials and on the sagittal scan. And all the measurement was done by an academic consultant neuroradiologist. And this is what we looked for. This is different areas which I go through them. We did study the intracarotid distance, but as I said, we did not find anything new. We confirmed what's in the literature. So this is how we measure the intracarotid distance on the MRI. But we also saw is really the vertebro-basilar junction when it's reconstruction. How far is it from the pontomedullary junction? And it is really either at it or within a short period. So they correlate. And also we found how many are in the midline or paramedian. We looked at the sphenoid sinus floor for morphometry. And where is this junction related to the clivus from top to bottom? But really what is important is how much is the distance between the floor of the sphenoid sinus and the vertebro-basilar junction. And the reason why we know that, we wanted to know that, because when you see the scan, you know where you can reach, but also intraoperative for intradural lesions. I'm not talking about extra, that how to find this anatomical parts. Then we did this measurement, which I will show you why it is the entrance from the navium to the heart, to the heart palate in the front. And because mainly, although the floor of the sphenoid sinus was straightforward on most of the cases, but we had, in 100 cases, you would imagine we had variation. So here, where is the floor? Is it here or this point? And here, the similarity. So we wanted really to find this point, the point where the floor hits the clivus. And in most cases, that was found on a line that is 1/3 of the distance between the superior and inferior line, like that. And that point correlated with the floor of the sphenoid sinus, and we looked at its relationship. So these are the figures that is important. And what you could see is this figure here is the distance from the sphenoid floor. There is variation, but it is a good landmark. And if you have difficult identification, you can use this, which is in the middle of your view because the endoscope is in the upper third. So this is where you are working at. So this is the example of a Trans-Clival approach where the video is from 2011 or 13. This is a pediatric case with a strict nerve palsy. And this is a tumor that is intradural. You can see it's in the cavernous sinus. It is medial to the carotid in the cavernous sinus, going to the petrous epic, and reaches the prepontine space, the initial part, which may be blurred a little bit, but to drill really the remnant bone of the clivus and identify the paraclival carotid on each side. As you can see here, it's clear. Then the bone is really eroded in the middle. This is one side, this is the other side. And here we are in the midline. And you can see the dura is defective, and you can already see the gelatinous tumor extending from the dura intracranially. The dura is open more widely. This is the bottom here, this is the top, and it's very easy, as you know, most chordomas are easy to resect like that. And we see now the basilar, we are strictly in the midline. Then when we look down, we identify the sixth nerve, we extend the thing because we have cleared the tumor from here. And then if we look downward here, this is the basilar, we clear it. This is the ICA, anterior inferior cerebellar artery, in relationship to the sternal sixth nerve. And the sixth nerve is going to the cavernous sinus here, as you can see. There is some bulky mass behind it. We haven't cleared all the lumps over the dura yet. And then if we look at the prepontine cisterns, we have this is the perforator, and this is the ICA. There is some adhesions here, and here you find this is the floor, and really this is the vertebral-basilar junction, and that was the origin of the sixth nerve coming, and it goes diagonally superior and lateral, and we clear the top part where you have the basilar bifurcation, superior cerebellar artery, but there is a tumor extending along the sixth nerve as it enters the medial part of the cavernous sinus. This is a pediatric case, only 14 years old, and we have starting to clear more of the dura, as you can see, and then we open the medial cavernous sinus, and initially you get the tumor, as you can see here. It is clear. We explore more, as you can see in the moment, the cavernous sinus, whether there is any remnant. This is not the whole cavernous sinus. We are medial. The carotid is there. Unfortunately, this doesn't show you a clear carotid, but you can see how much the bleeding from a clear medial wall of the cavernous sinus, which can be controlled, as you can see in a minute, with some Surgicel. That's all it needed. Despite it looks frightening at some stage, and then we repaired, as you all know, the nasoseptal flap. Of course, before we remove the nasoseptal flap, as you can see, we cleared everything on the dura. Sometimes we resect the infiltrated dura, and we put the fat to allow the basilar and pons to be away if the patient, when the patient went for proton therapy. So the landmarks that we use when this distorted anatomy, this one was not too bad, but sometimes you cannot clear, you cannot see the sixth nerve. That if you remain really in the midline and don't go laterally where the sixth nerve will be adherent to the dura and you can injure it, you go in the midline, identify the vertebral junction, go a little bit paramedian. This is the pontomedullary circuit. The sixth nerve, you can detect it here. The pathology will be superficial for it, and then you follow the nerve cephalad. You will decrease the injury to the sixth nerve in difficult cases. So the sphenoid sinus floor, as Dr. Amin Kassam did mention and observe, but we study it further, is a good landmark for beginners, and it predicts where the pontomedullary junction and hence where the sixth nerve, and it is valuable when everything is distorted. And thank you very much for listening to the simple talk.
Thanks a lot, Professor Ramez, for this excellent presentation.